Hi, welcome everybody. Welcome to another MCQ live sessions from Medico Apps. I'm Dr. Abhishek, your mentor for uh, MCQ sessions at Medico Apps. Just let me know if you can see me live. Okay, great. So I can see my live feed. This is the sixth session of the Medico Apps MCQ Live. So this is the session inspired by so many of my students constantly saying that, sir, whenever you taught us theory, we forgot in the examination, and whenever you discussed an MCQ, we remembered in the examination. So these series of sessions are on high topics, on actually questions which have appeared in previous years, so that you can practice those previous year questions and know what were the concepts behind it. And if and almost 70-80% of the questions will be on the same topic and you can get it correct in the examination. So this is session 6. We have two more sessions. So every week we are planning 4 sessions, generally around 4:30 in the evening. The eighth session is around 1 o'clock in the evening. So with this, if you are new to this channel, a request to subscribe to our channel. We already have in a very short span, we have crossed 37,000 subscribers, which is a very big number for me. Thank you so much, everybody. Give this video a like, because then what happens, this video gets saved in your like video history. If you have any questions on this session, even after the session, you can leave a comment, or if you have a recommendation of upcoming sessions, what kind of questions to take, you can put it in the comment. And if you like this session, at the end I would request you to give this session a share, so that it is shared with your friends. One last thing, every day I send personal updates in form of some groups which I have created, and these groups I share concept card, which are visual cards on high topic. I send short videos or quizzes, master classes are the full length classes, and live session notification. For example, this session is currently there, so there will be notification of these sessions. A lot of free PDFs, or mini courses which we create. All these things are sent directly to your WhatsApp. It's a free group, and because it is a group, so you can always exit if you don't find the updates very well. But I'll request you to go and join groups. The best part is I have created groups separately for first year, second year, third year, final year intern batches. So if you're a first year student, you will only get updates related to anatomy, physiology, biochemistry, and so on and so forth. So I would request you to go ahead and have a look at this particular groups. So go to medicoapps.org/groups and join our groups. The link to those groups will be also in the description of the video. Let's look at the first question. So this question is on ABD analysis. Let's read the question. A climber is coming down after trekking to high altitude. So he has blood tests drawn, and the pH finding is 7.55, PCO2 is 12, PO2 is 30, and bicarb is 20. So what does it demonstrate? Okay, so again, lot of ABD questions. So I have told you how to handle ABD questions within 10 to 15 seconds. You can handle any ABD question. So the first step is to decide if there is an acidosis or alkalosis, right? So in this case, to understand if it is an acidosis or alkalosis, what should you do? You should first see the pH. So what is the normal pH? So the normal pH is by 7.35 to 7.45, right? So here we can see the pH is higher. So higher means alkalosis. So yes, it will be alkalosis first of all. Now when we talk about alkalosis, it can be metabolic or it can be respiratory, right? So always you have to rule the respiratory metabolic respiratory alkalosis first. So respiratory alkalosis means the person is hyperventilating, so his carbon dioxide level will be less. Then only it is a respiratory. For example, if it is a respiratory acidosis, his PCO2 should increase, and if it is a respiratory alkalosis, then his PCO2 should decrease. This is very easy to understand. Now, in this case, if you see, the PCO2 is 12. Okay, what is the normal PCO2? Anyone can write in the comment. What is the normal PCO2? So this normal value you have to remember, it is 35 to 45. So we see that the PCO2 is decreased, which means the cause is respiratory. So it is a respiratory alkalosis. So automatically these things will get cancelled. Now we are left with two options. So it is a respiratory alkalosis case. Now, what do we understand by uncompensated or partially compensated? Now, suppose it is an alkalosis, we have seen. So, if it is an alkalosis, what will happen to try to correct it? Okay, so bicarbonate is the correcting mechanism. Okay, bicarbonate is a base. So, if it is already an alkalosis, what should happen? The bicarbonate value should further go down. Understood? And if you see, the normal bicarbonate is 22 to 26. So here the bicarbonate is 20. So already the body is trying to get rid of bicarbonate. So it is compensating, but fully compensation it has not happened. So compensation has started. So it will be partially compensated respiratory acidosis. Any doubt in this question? So again, I will tell you the algorithm so that you are very, very clear. So at the first step, whenever an ABG question is given to you, make sure first you decide if it is an acidosis or alkalosis. What is the best way to decide? You will look at the pH. So pH is 7.35 to 7.45. Okay. So this is the normal pH. Anything below this will be your acidosis. Anything above this will be your alkalosis. Okay. Now, once you have decided acidosis and alkalosis, always rule out the respiratory cause. So, first we are going to rule respiratory acidosis. Now, when I talk about respiratory acidosis, PCO2 has to increase. So, if it is increased, we know it is respiratory acidosis. If it is decreased or even normal, even it is normal, then it is metabolic acidosis. Similarly, when we find a case of alkalosis, we first rule out the respiratory alkalosis. Okay. So how do we rule out respiratory alkalosis? In respiratory alkalosis, the PCO2 will definitely fall down. So if it is fall down, if it has fallen down, then it is respiratory alkalosis. And if it is increased or normal, then it is metabolic alkalosis. And about compensation, the third thing which they have asked is about compensation. So we know that if it is a respiratory acidosis, okay, so primary defect is in the carbon dioxide. So bicarbonate will be the compensatory mechanism. So what is going to happen in, because it is an acidosis, the bicarbonate value should be increased. If it is a metabolic acidosis, the compensatory mechanism will be carbon dioxide, and because it is an acidosis, the carbon dioxide should decrease. Okay, because carbon dioxide is acid. So if carbon dioxide is increasing, acidity will. If it is a respiratory alkalosis,
Okay, I've found this.
okay. So is it clear, everybody? So if it is a respiratory alkalosis, so again the compensatory mechanism will be bicarbonate. Because it is an alkalosis, so the bicarbonate has to come down. Okay, that will be the mechanism. And if it is an metabolic alkalosis, the compensatory mechanism will be carbon dioxide, and because it is an alkalosis, the carbon dioxide should increase. Is everybody clear about this particular question? Any doubt? Just let me know in the comment section. Anyone? Any doubt in the comment section? Okay, great. So let's look at the next question. All are true about food maps, diet, except. This is the next question. All are true about the FODMAP diet except. Your options are: it includes fermentable oligosaccharides, diet low in FODMAP reduces IBS symptom, FODMAP is highly absorbed through intestine, and fructose is an example of FODMAP. So what is the wrong option in this? Because it is saying that all are true of FODMAP diet except. Now remember, so let me first talk about this particular concept. So here we are talking about a very important topic called as irritable bowel syndrome. So we have seen what is IBS. Basically, it's a functional GI disorder. What is IBS? It's a functional GI disorder. Okay, and what are the characteristics of this functional GI disorder? That there will be abdominal pain and change in the consistency of the stool. Okay, there are so many etiological pathogenesis is not what very clear. But generally, what happens is there is a change in the firmicutes and bacteroids ratio, FB ratio. So basically, dysbiosis is one of the reason. How do what are the clinical features of IBS? So it will present as a recurrent abdominal pain. Remember, it is a diagnosis of exclusion. So out of the three things which I'm going to mention, two has to be present. So what are the three things? Abdominal pain, okay, and remember this pain has to be more than one per week for at least 3 months, okay, one episode per week for at least 3 months. Second is change in the consistency of the stool, and the last is change in the appearance of the stool, okay. So out of these three, one should be there, abdominal pain should be there, and out of these three, two should be there, okay. Very characteristic will be there will be sometimes there will be diarrhea, sometimes there will be constipation, and when there is a constipation, the characteristic thing is that this constipation is not relieved by laxatives. Very characteristic, okay. When you are giving laxatives to this patients also, they will not be relieved, the constipation will not be relieved. If they have diarrhea, so they will have a low volume diarrhea, very characteristic, which means the per day output of stool will not be more than 200 ml. Very important, it will not be a high volume diarrhea, okay. So this is about irritable bowel syndrome. Now when we talk about FODMAPs, basically it is used in the management of irritable bowel syndrome. So let's look at the treatment, okay. So first and the most important thing is dietary modification. So when we talk about dietary modifications, what are the dietary modifications which you have to do for irritable bowel syndrome? First, very easy to guess, high fiber diet. So we have to increase the intake of diet, which will correct the disbalance of the firmicutes and bacteroids. Second is we have to decrease the intake of FODMAPs. What does this FODMAP stand? That is what you have to remember. And this is the question which was asked in the examination. So F stands for fermentable oligosaccharides. F is for fermentable oligosaccharide, disaccharide, monosaccharide, and P is for polyols. Okay. So FODMAPs is fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, and lactose is not fermentable, so it will not be a part of this FODMAPs, okay. So this dietary modification FODMAPs question was asked to you. And yes, if it is a constipation, then there are certain drugs like 5-HT4 agonist like tegaserod. So when we talk about management in terms of drugs, so you have a drug called as tegaserod, which is basically a 5-HT4 agonist. Okay, then you will have for diarrhea you can give loperamide or cholestyramine. Antispasmodics you have to use. Even SSRIs have been shown to show a lot of relief in these patients. Okay, so here fermentable oligosaccharides, this is also correct. Highly absorbed, yes, this is correct. That is why they have to be avoided, and the correct answer is D. This is a fructose is not an example of FODMAP. Is everybody clear about this particular concept? Is everybody clear? So let's move to the next question for today and identify the linear Weaver plot. Okay, so linear Weaver plot, whenever we see the enzyme activity, we see it with the velocity of the reaction and substrate concentration. Okay, so linear Weaver plot is when we look at 1 by V and 1 by S. So this is the linear Weaver plot which has been given to you. So you have to identify, is it a competitive inhibition, is it a non-competitive inhibition, is it an allosteric inhibition, or it is an uncompetitive inhibition. Okay, so let's look at the first, that is your first option, that is your competitive inhibition. Okay, so when we talk about competitive inhibition, so what happens in competitive inhibition? In competitive inhibition, let's say this is your enzyme, okay, and this is your active site. So there is an inhibitor which has a structural similarity to the substrate. So the inhibitor will come and attach to this active site. But remember, this attachment is reversible. So what you have, if you plot a curve, okay, and in this end you will plot the substrate concentration, and in this you will plot the velocity. So suppose this is without the inhibitor, so this will be with the inhibitor. Okay, so we are seeing that the Vmax is not changing, but the Km value is actually increasing. So this was Km normal, and this is Km with the inhibitor. Okay, so when we draw a line viewer, okay, so this will be the normal. Remember, this is 1 by V and this is 1 by Km. Okay, and this will be with the inhibitor. So this is K 1 by Km. Okay. So here you see the X intercept does not change, which means the Vmax is not changing. So a very important point is whenever in inhibitions, when Vmax does not change, so X intercept will not change. Okay. And in conditions where Km is not changing, okay, then Y intercept will not change. Okay, in this particular case we are seeing that X intercept and Y intercept both are changing. Is it clear? So competitive inhibition goes out of here. Let's talk about non-competitive. So what is a non-competitive inhibition? When we talk about non-competitive inhibition, basically if this is your enzyme, okay, the inhibitor attaches somewhere other than the active site, and it attaches in a irreversible fashion. So if we have to draw a curve, so this is the normal curve without inhibitor. With inhibitor it will come down, but however the Km value will remain the same. Km value does not change in the non-competitive inhibitor. So in that case, what is going to happen? In that case, we know that here this intercept also will change. Is it clear? So even non-competitive inhibition is ruled out. Let's talk about allosteric inhibition. Now, allosteric inhibition, the curve is a sigmoid curve, and for sigmoid curve, we cannot draw a linear Lineweaver curve. So this also goes out of the window. So the correct answer is uncompetitive inhibition. So anyone knows what is an uncompetitive inhibition? So basically uncompetitive inhibition, what happens? Suppose this is the enzyme. So inhibitor will not bind to the enzyme. Only when the enzyme and the substrate are bounded, at this point the inhibitor will attack. Okay. So, and it is an irreversible attack. So here the Vmax will decrease and the Km will increase. Is this clear? So this is basically a graph of uncompetitive inhibition. Any doubt in this particular question? Anybody? Any doubt? So again, I have taken a lot of sessions on what we called this inhibition of enzyme. Very important topic, conceptual topic. But if you go through it, you will be able to answer at least one question in every examination is around inhibitions. Okay. Let's look at the next question. And this is a clinical question. So a 4-month-old boy is brought to a physician because of seizure. He was delivered at term after uncomplicated pregnancy. Currently, he is 10th percentile for height, 5th percentile for weight, and 15th percentile for head circumference. So we are looking at a boy who is stunted in growth. Okay, there is muscle hypotonia, and here is where you start getting your cues. His lactic acid and alanine levels are increased. Functional assay of pyruvate dehydrogenase complex shows decreased enzyme activity. Okay, supplementation with which of the following substances should be avoided? This is your question. Now let's understand the concept. Pyruvate dehydrogenase complex, what does it do? Can anyone write what is the function of pyruvate dehydrogenase complex? So we know that pyruvate is converted to acetyl CoA and it enters into the mitochondria because of this pyruvate dehydrogenase complex. So if there is a decrease in the activity, all these pyruvate, where it will go? All this pyruvate will either be converted into lactic acid, okay, or it will be converted into alanine, and this is what is given in the question. There is increased level of lactic acid and alanine, okay. If it takes an amino, it will be converted into alanine, and if it takes the hydrogen, it will be converted into lactic acid, okay. So we have to avoid in this case anything which will increase the pyruvate levels, because more pyruvate levels, which means more lactic acid, more alanine, and the symptoms will increase. Is it clear, everybody? Is this concept clear? That here the reaction which is affected is the conversion of pyruvate to acetyl CoA, okay, because PDH is involved here, okay. So this pyruvate is going to alanine and formation of your uh, lactic acid. So anything which will increase any one of these should be avoided. So let's look at arachnoid acid. Now arachnoid acid is basically a fatty acid, and we know that fatty acid will not increase the level of pyruvate because it has a different, it will directly be broken down into acetyl CoA. So this can be given, and in fact this should be given, because the problem is in the carbohydrate metabolism, so we should give fatty acids. Let's look at thymine. We know that PDH, what is the cofactor? Thymine. So if any enzyme is deficient, is not working properly, we will try to augment the enzyme by using the cofactor. So thymine also should be supplemented. Now your two options are valine and lysine. So if you see, valine is a purely glucogenic amino acid. It's a purely glucogenic amino acid. So all this valine will be converted into pyruvate. So this should be avoided. Whereas lysine again is a purely ketogenic amino acid. So ketogenic amino acids you can give, because ketogenic amino acids will directly form acetyl CoA. Is everybody clear? So the correct answer here will be. So this is the concept behind it. So let's look at another very important thing which is asked, and that is around your classification of amino acid. Very important. So here we were able to solve on a concept that there are some amino acids which are ketogenic and there are some amino acids which are glucogenic, and we should avoid glucogenic amino acids in this case. So let's look at the classification. So when we classify amino acids, we can first broadly classify the amino acids into three categories. Okay, so one is aliphatic. Aliphatic means straight chain amino acid. Second is aromatic. Aromatic means they will have aromatic rings. And the third is amino acid. Can anyone tell me what is an amino acid? We know there is only one amino acid, that is proline. Okay, let's talk about aromatic amino acids. So aromatic amino acid again can be divided into homocyclic. Very simple to understand that in the cycle, everything is made up of carbon. And the second is heterocyclic, which means in the cycle, along with carbon, there will also be nitrogen. So homocyclic, we have two, phenylalanine and tyrosine. Okay. Heterocyclic, again we have got two. We have got tryptophan and we have got histidine. This classification is very important. That's why I am teaching. Okay. Now let's look at aliphatic. Aliphatic is simple. Then we have got branched, and then we have got with a special functional group like OH, sulfur, amide, and then we have got acidic amino acid and basic amino acid. Okay, simple, we have got two simple amino acid, glycine and alanine. Okay, when we talk about branched, we have got three: leucine, isoleucine, and valine. With OH, we have got two: threonine and serine. Sulfur, we have got two: cysteine and methionine. Amide containing, we have got two: asparagine and glutamine. Same if you just convert it into acid, aspartic acid and glutamic acid is acidic. And basic, we have got, so this histidine is basic amino acid, and apart from that, we have got arginine and lysine. So this is the classification of all the amino acids. Now we have to know certain other classification. This is based on the structure. So the next question they are going to ask you is, what are the essential amino acids? So what are the essential amino acids? And this is what you have to know. Essential amino acids are the amino acids which your body cannot make. So remember, our body cannot make branch chain amino acids. So all the branch chain amino acids are essential. Our body cannot make aromatic amino acids. So all the aromatic amino acids are essential except tyrosine, because phenylalanine can be converted into tyrosine. Also, one from the OH group, threonine, and one from the sulfur group, methionine. So these two again are essential amino acids. Rest everything is non-essential. Any doubt? So I have told you our body cannot make branched chain amino acids, our body cannot make aromatic amino acids, and our body cannot make one from OH and one from sulfur. So these are the aromatic. These are the essential amino acids. Okay, all the other are non-essential amino acids. Our body also cannot make basic amino acids like arginine, lysine, and histidine. Okay, so these are the essential amino acids. Okay, so let me just list down all the essential amino acids so that you will remember it. So remember, first of all, our body cannot make branch chain amino acids. Our body cannot make aromatic amino acids. Our body cannot make basic amino acids. And one from OH group, that is threonine, and one from sulfur group, that is methionine. Okay, so these are the amino acids which are basically essential amino acids. Rest everything is non-essential. Another very favorite question they will ask you is, based on the metabolic fit. Based on the metabolic fit, they can be glucogenic, they can be ketogenic, and they can be both glucogenic plus ketogenic. So remember, ketogenic, we call it as lovebirds, lysine and leucine. These are the two birds, like people in love, they will always be separate. So this entire group can form glucose, but lysine, these two are the only which will never form glucose. So lysine and leucine, two people, they will never form glucose, so they are separate, ketogenic. When we talk about glucose plus ketone, these are fit amino acid, FITT. Okay, F is for phenylalanine. We know the single letter representation of phenylalanine is F. Then I is isoleucine, tryptophan, and tyrosine. So these are the fit amino acid, which means they can produce both, you know, glucose as well as ketone, and all the other amino acids are purely glucogenic. Is it clear? So this is the second classification. Any doubt till now? Okay, and the last is, they will ask you, keep asking you, what is the acidic amino acid. So we know these are the two acidic amino acid. What are the basic amino acids? So arginine, lysine, and histidine, these are the basic amino acids. Okay, so these were some of the questions on classification of amino acids. So this brings us to the end of today's session. So we have, in today's session, we have discussed some very critical questions around classification of amino acid, around irritable bowel syndrome, around enzyme inhibition, and we also had a ABD question. Okay, and I understand that most of my students suffer from uh, revision as a challenge for them, and because of not properly revising, they lose their precious PG seat. So they've been working hard, they will keep solving MCQs, they will keep watching videos, but revision is a constant challenge. And why is the revision such a big challenge? Because if you see, when you revise, there's lots of information. It's super boring to revise, right? Watching a lecture, solving MCQ is interesting, but revising is very boring. And even if you revise, many students say that they keep forgetting. So what is the what that we can do? So what we have created is something called as concept card. And in concept card, we pick up only the high topics which are frequently asked. We convert it into an image and flowchart based information. And the way we present is not just giving you the flowchart. It will be like an interactive learning. There will be a question, then one step will be shown, another question, another step will be shown. So it's more about active learning so that you do not forget in the examination. If you want to have a look at the concept card, there, the link will be in the description. You can go onto the Play Store and simply type Medico Apps concept card. You will get that app downloaded, and there is a 14 days free trial, so you can download it. So this brings us to the end of today's session. Okay, and make sure that you like, share, and comment. And if you are new, again, please do subscribe and At the end, one simple request: if you want to stay connected, if you want to learn more, make sure that you connect us on our daily update on WhatsApp. The easiest way is go to www.medicoapps.org/groups. So if you go to that, there will be separate groups for first year, second year, third year, final or intern, post intern. Simply join the group which you according to you, because then uh, uh, according to the group you have joined, you will get the updates. So this brings us to the end of today's session. Thank you so much, guys. Thank you so much. And again, the next session is tomorrow at 4:30. So